Hello, my name is Yejun Hong. I'm a medical student in the University of Calgary, and our team is here to explain retinopathy of prematurity as a link between ophthalmology and pediatrics. The eye overall is made up of countless parts, complex anatomy, and many different layers. So it is a complex organ that takes a lot of time to develop. The eye as an organ fully forms by week 26 out of 40 of pregnancy, but angiogenesis for the retinal vasculature needs to continue developing its intricate network up until 36 to 40 weeks until delivery. Therefore, retinopathy can develop in instances of prematurity, and is closely associated with low birth weight, preterm delivery, and oxygen administration through iatrogenic means. So, retinopathy of prematurity, or ROP, is an abnormal retinal vasculature development due to the shortage of adequate developmental period for angiogenesis, and this is usually a diagnosis in neonatal stage. Let's take a look at the forward-facing view of the retina. There are a lot of different vessels, including the retinal veins and arteries, and they all sprout out from the optic disc. The optic disc is at the nasal portion of the retina, and at the temporal side we can see the fovea and the surrounding macula. This is where the visual information for your central vision is collected. In terms of pathophysiology, while the structure of the eye is complete in its growth by week 26, angiogenesis of the retina starts by 16 weeks at around the optic disc. This pans out peripherally to all the hypoxic regions of the retina through VEGF stimulation. However, this does not finish developing until after delivery. Then while nasal retina, which is close from the optic disc, is fully vascularized, temporal retina is not yet developed by delivery. So even at 36 to 40 weeks, the temporal artery has not been fully vascularized. So when the delivery is preterm, you can see you may expect that the retinal vasculature is even less complete. The premature delivery with complications requires special attention from the hospital. Supplementally, oxygen therapy may be applied to keep the baby breathing and to prevent peripheral cyanosis. However, this oxygen supplementation increases the available oxygen to the retina. While this sounds at first an advantage for the eyes, it is not in the case of development. The ideal partial pressure of oxygen for retinal vasculature growth is 25 to 35% because the stimulus for vasculature growth is hypoxia. The body needs to sense that the vasculature needs to grow and the tissue needs to be better supplied with oxygen. But with iatrogenic means, if the retina already gets enough oxygen, there's no need for vasculature to fully develop. As we talked about, VEGF promotes the growth of new vessels and responds to a hypoxic state. IGF-1 is another hormone that permits the action of the VEGF. Low level of this hormone means that VEGF may not be as effective in its role. So although there's a hypoxic state in the retina and there's a lot of VEGF. If there's low IGF, the VEGF will not be able to exert its full effects to angiogenesis. IGF-1 is delivered through the placenta, so after delivery, the IGF-1 level is bound to be low. So premature delivery with supplemental oxygen means there is less VEGF and there's less IGF-1 because there's no more connection with the placenta. The risk factors to developing ROP is if the birth is premature, especially with less than 33 weeks of gestational age. If the baby is low in birth weight, ROP can occur more frequently. Supplemental oxygen therapy, as we covered, prevents the release of VEGF for proper angiogenesis. Complicated hospitalization can lead to oxygen therapy, and prematurity, even less than 36 weeks, can begin to have an effect.